You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you've enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcast. I have a returning guest, the company being the returning guest, but someone different there, talking to BIOLIFE4D. This time talking to the CEO, Stephen Morris. I know the company had such an interesting product that they were working on that I wanted to have them back to hear more. So, Stephen, thank you for coming.
It's my pleasure. Glad to have the opportunity to talk about BIOLIFE4D.
Yeah, and for listeners that may not have heard the other podcast, what's the premise of BioLife? What do you guys do?
So BIOLIFE4D is a group of people that we've put together in order to work on some pretty incredible technology. The leading cause of death globally, literally taking 1 out of every 3 lives around the world, is cardiovascular disease. And what we're working on is bioengineering a human heart viable for transplantation out of a patient's own cells. So the technology that we're working on will address the major issues that currently exist with donor hearts or donor organs or lack of donor organ challenges that currently plague the world.
So, what's the state of donor organs, especially in terms of hearts? How many are needed each year, and how many are actually donated, and what are some of the stats?
Yeah, so the incredible thing is there's only 3,500 people really on the heart transplant waiting list in the United States. And it's not because only 3,500 need it. There's about 200,000 people that actually could use a heart transplant to save their lives. But the problem is only about 3,500 heart transplants take place in any given year in the United States. You've got a huge challenge with the lack of supply. So even though there's all these people whose lives could be saved, only 3,500 people are on the donor waiting list. All the other people just aren't allowed. They have to literally ration those 3,500 for the people that have the highest probability of success. Everybody else just doesn't even have a chance.
Yeah, that's terrible. When hearts are transplanted, what are some of the criteria that's needed to make sure that the heart will work? Like, I guess obviously blood type has to match, but what are the other criteria?
There's a bunch of different criteria. One of the reasons that it's so difficult is because in order to prevent rejection, you need to have similar types of blood characteristics and things like that. But also, you just can't, even if you want to donate your heart, there has to be certain circumstances that are met for the organ to be viable. So the heart needs to still be beating. Someone needs to be really brain dead, and then they're able to remove that heart from that particular donor. Once they do that, there's a very limited amount of time that there is before that organ needs to be transplanted into the recipient patient. And if you think about it, there's only about a 2-hour radius of where that heart could be, because they have to transport that heart via typically from the hospital where it's harvested via helicopter to an airport, then flown from an airport to another airport, then flown on another helicopter to the hospital, brought down to the operating room in order to be transplanted. So it's very, very difficult in order to meet the criteria as far as having something that is a heart that's functional enough to work, that's about the same size, and that's a close enough genetic match. One of the really incredible parts of our technology is when we bioengineer the heart, not only are we addressing the supply issue, but the main challenge that there is in donor organs is that your body wants to reject it. Your body senses that that's something foreign that's just been implanted, and it wants to reject that organ. So you have to shut down the immune system to prevent that rejection. Our technology, we take a patient's own cells and we literally reprogram them into the different cells that make up the heart, and then we bioengineer a custom heart just for them, made out of their own cells, so that their body doesn't reject it.
In terms of so making it out of their own cells, what are the cell sources, and what's the process? Do you culture cells and then induce them to pluripotency, or what's the path?
Yeah, so what we do is this. We start with the patient. We'll take a sample of the patient's blood, and from that we'll remove the white blood cells. And once we have the white blood cells, we're able to literally reprogram those cells. So blood cells are specialized cells. All cells started out as stem cells, but the body communicated to those certain stem cells and said, we need you to change from a stem cell into a specialized cell, in this case, a white blood cell. So each of the cells having strands of DNA in that cell, it's like a library of knowledge. So each of the cells are able to change themselves into whatever the specialized cell types are that the body needs. In our case, we take these white blood cells, and what we do is we reprogram those white blood cells to become what's called induced pluripotent stem cells. So we induce them back to the stem cell state. This is a technology that's only about a decade old. Up until about 10 years ago, it was thought that once stem cells became specialized cells, whether it be heart cells or blood cells or skin cells or whatever type of cells, it was unidirectional, that was it. But about 10 years ago, it was discovered that we can communicate to these specialized cells and reprogram them to go back to their stem cell state. And those are called induced pluripotent stem cells. They're induced because we're inducing them, we're programming them back to the stem cell state. Once we do that, we're able to grow those stem cells to make more and more and more of them until we have enough volume of cells, and then we can section off those cells and reprogram them again, called differentiation. We reprogram again into the different cell types that make up the heart. So there's cardiomyocytes, which are cells that are beating. There's smooth muscle cells. There's endothelial cells. There's cells that control the electrical signals that work within the heart. And so we make all of those individual cell types, and then we use those as the building blocks to literally bioengineer this heart. So what we do is once we have all the proper cell types, we put them into our bio ink, is what we call it. And basically it's like little drops of hydrogel, and inside those drops, think of it almost as a snow globe. If you shake up a snow globe, you see all these things floating around. Well, in our case, it's these individual cells as well as growth factors and nutrients and other things that we put in there, our secret sauce, in order to keep everything viable during the printing process. And then what we do is we use a very specialized type of 3D printing called bioprinting, which is just a very highly specialized 3D printer that's designed to print with biological materials and keep those biological materials alive during the printing process. So what we do is we lay those cells down layer by layer, building up bioengineering this heart. We lay down also other cells that hold everything in place, and then once we're done with that, the cells join together through the natural biologic process. We melt away the scaffolding, or the cells that we use to hold the cells in place, and you're left with the organ. Really, all we're doing, it sounds like an incredible process. It is an incredible process, but all we're doing is we're providing the same type of conditions that happen naturally within the body, just outside the body. And we're tricking the cells to do what they do naturally inside the body. We're just having them do it outside the body, and we're directing them to go the way that we want them to go. So we end up with the same final product.
So you're culturing cells from the person, then inducing pluripotency, then differentiating them into all the necessary cell types, making the ink,
printing it, et cetera, all the steps you went through. So going through that process, what cells are the ideal cells to take from the person to induce pluripotency? And I would think maybe the particular heart cells themselves would be easiest, but they're hard to get at and invasive. Did you use skin cells or fat cells, or what's used?
No, we use white blood cells. Different people use different types of cells for different applications in this similar types of process. A lot of people use fat cells. We found it the best cells for us to use are white blood cells. So there's some technical reasons that also lead into that. When you're changing cells from a specialized cell to induced pluripotent stem cells, or those induced adult stem cells, and then differentiating them into the types of cells that you want. If you don't use the right types of cells or the right combinations of cells, you can have very immature cells at the end of your process. So even though it's something that would look like a heart, it may not function properly. It may not be mature enough cells in order to function the way we ultimately will need it to function, which is to be able to go into a person after being transplanted and survive that person for the rest of their life. So there's a lot of technical factors that go into that, but we found the ones that we're having the most success with is the white blood cells.
And the white blood cells can make all the different constituent cell types in the heart, or are they good for only some, and then maybe another blood cells are better for others?
No, the white blood cells themselves don't make any parts of the heart. The white blood cells get converted back to adult-induced stem cells, and then those stem cells are able to be made in each of there's primarily 6 different types of cell types that make up the heart, and those stem cells, those induced adult stem cells, can make each of those individual types of cells. There's other processes that don't really work for our type of application, where you can actually change a specialized cell like a white blood cell directly into a heart cell, but those cells are typically not mature enough for us. The other problem with that is the volume of cells that we need in order to do a three-dimensional organ like a heart. So the volume of cells are in the billions, and you can't take that many cells out of, for instance, of somebody's white blood cells. There's not enough of them. So you need to first convert them to stem cell state, where you're able to then have those divide or keep multiplying and making more and more and more and more until you have enough volume of cells that you can then differentiate into the individual types of cells that you need in order to bioengineer the heart.
Gotcha. How far along are you in the process? Have you been able to create a fully functional heart, or which stage are you at of doing this?
No, so nobody's been able to do a fully functional heart yet. That's ultimately what our goal is, our objective is, because we know once we're able to do that, we'll be able to save millions of people's lives every year. So that's our ultimate process. There's really 2 reasons why we chose the heart. The first one is because of the huge need, the global need. If you think about it, if 1 out of 3 people die of cardiovascular disease, and there's about 7.5 billion people in the world, it's a lot of people that die of cardiovascular disease. But the second reason that we're doing it is because on the way to our full heart, which is our ultimate goal, the heart is made up of different components like valves and grafts and other types of things that we can take and bring out to the market on our way to our full heart viable for transplant. We call each of those our shots on goal. Sometimes we call them our milestones. So the first milestone that we did was our cardiac patch. So we took these blood cells, we went all the way through the process, and we were able to make literally beating, living human heart tissue. And we call that our patch. And then after that, we continued on, and we just recently had a really exciting breakthrough. We had our proof of concept for our mini heart. Now, our mini heart is not a fully functional human heart shrunk down, but what it is, it's made up of all of the components of a human heart, the valves and the chambers and things like that. And ultimately, it's got a lower bar. So the bar that we need to satisfy with our mini heart is for really drug discovery testing purposes, in particular cardiotoxicity purposes. So the heart doesn't have to function well enough to survive an animal or a human long term. It just needs to function well enough to be able to give a better predictive value for that type of testing. So there's a huge need right now in that type of testing. Any type of new drug that goes to the market has to go through the FDA process, and the last thing you do before your human trials is they have to test the cardiotoxicity. Is this particular drug going to have negative effects on a human heart? Well, the model that they have to use now is an animal model, and the reason that they do that is not because people are sadists or anything like that. It's because it's the best predictive model that there is prior to going to humans. The problem is it's not a terribly accurate predictive model. So one of the main reasons that drugs, when they go to the human population for human trials, fail is because of this negative effects on the heart. So by providing these drug companies, the pharmaceutical companies and drug discovery companies, a more predictive model. After all, what's better at predicting what a human heart will do than a human heart, even though it's a shrunk down version of it? So by providing this better predictive model, it provides a safer product going to the market, but also it's of huge interest to the pharmaceutical industry because these failed human trials, inexpensive ones maybe are $50 million. Expensive ones can be over $500 million. So that's a lot of money to risk. So if they could have a better predictive model before they risk that kind of money, it's really gold for them. And as a side note, people that are animal lovers, like myself in particular, love this mini heart concept because it's for the first time represents an opportunity to be reducing animal testing. So if we can provide a more predictive model than the animal model, it's something that can ultimately be used instead of the animal model, and therefore saving. Exactly, right.
When it comes to cardiac toxicity, I don't know if you'll know, and it's okay because it may be a very difficult question. Does it tend to happen very soon after a drug is taken, if you look at the literature, or does it take quite a bit of time, maybe suggesting that a drug was digested and metabolized and then it caused cardiotoxicity? Or is it direct because it's in the bloodstream, boom, it hits the heart?
Yeah, so those it's an excellent question, and the answer is yes and yes. So some of the testing is longer term testing, some of it is shorter term testing. The specific testing that we're talking about doing is shorter term. So it's anywhere typically done for a matter of a few hours to a few days. So that's one of the reasons why the bar for our mini heart is lower than the human heart. It doesn't have to survive for the rest of an animal's life. It only has to be able to survive for a matter of days or weeks. And one of the key components of that is the vasculature. So vasculature is one of the key components and one of the challenges really that there are in bioprinting an organ. Because even if you bioprint an organ, in order to keep it viable, the blood has to flow to all these cells to provide oxygen and nutrients and remove waste products. Without that vascularization, even if you were to bioengineer an organ, that organ would just die. And the vascularization is required for a mini heart, and to keep something viable for a matter of hours or days is much less significant than the vasculature ultimately that's going to be needed for a full heart viable for transplantation.
So how good are the organoids that you guys are making? Are they do they have all the cell types? Or are they just approximating a partial function of the heart? And are you able to achieve vascularization?
Yeah, so we're able to print vascularization. We're able to print the different components of the heart. Right now, what we're working is tweaking the function so that it'll give us that better predictive value.
Well, I remember this from engineering class. If you want to scale up something, it doesn't always necessarily scale up with the same dimensions, the same ratios of dimensions. Have you found that literally a smaller heart, an organoid, that some of the dimensions of the heart have to change in order to accommodate the changing pressures and differences in a smaller scale heart?
So typically, although all of it could be defined as organoids, really when you're talking about organoids, so most of the other companies that we're familiar with are working with very like maybe small groupings of just cardiomyocytes that beat or things like that. We're really working on a full three-dimensional model. So one of the challenges that we found is we can print these different components of the heart, valves and chambers and ventricles, things like that separately. But when you go to, it's not a matter of like a jigsaw puzzle. You just can't put those pieces together. We literally, when we're bioprinting this, we have to do it layer by layer. So we're finding that putting it all together at the same time is a bit more challenging than doing each step separately. Also, you're exactly right. As you scale up, it's just not a matter of like multiplying everything by 2. As you scale up, everything seems to be getting a little bit more complicated, a little bit more difficult. And listen, instead of using a couple 100 million cells like we are now, we'll have to be using ultimately billions of cells when we're doing a full volume human heart. And when you're doing that, there's a whole lot of other challenges that you have, like in working with that many cells, making sure that all of the cells are viable and they're all the correct type of cells. When we reprogram those cells to be the different types of cells for the heart, that some of those cells didn't accidentally get reprogrammed into the wrong types of cells. So there's as we scale up, it's not just multiplying everything by 2 or 3 or 10. Everything gets a little bit more complicated as you get larger.
Have you looked at embryology to see how hearts first develop in a person? Like, do they develop, from a center and then radially grow outwards? Like the 3D printing is layer by layer, bottom to top, but perhaps there's a way of 3D printing and turning slowly the sample that you're printing so you can approximate like a radially outwards construction.
Yeah, so it's a great question. The answer is yes, and we look at that, and it's very useful information, but we can't bioengineer a heart the same way. Keep in mind a couple of things. First of all, Mother Nature has taken millions and millions of years to perfect that process, and you're also starting out with embryonic stem cells and starting from nothing. So we can't use a similar type of process where something grows over a person's lifetime. Our product has to start out where it took that person their entire life to get to. So while there's some really good things and good ideas and things we try and pull from Mother Nature, there's other things that we just can't do similarly, although ultimately that's the best way to do it.
Yeah. What are some of the other challenges in creating the organoid? Do you have scarring that happens, or, is there enough cell-to-cell communication that the organoid, coordinates and beats and functions properly? Like, what are some of the challenges you run into?
Yeah. So some of the major challenges really are getting everything to work together. So if we print a valve, or if we print an artery, for instance, or we call it even like a graft, when we print the things separately, it's a lot easier to get them to work. When you're printing them layer by layer and everything is already integrated in together, getting the valve differentiated from the ventricle and things like that, it's really difficult to do that. So there's a lot of complication in doing it all at one time, like what we need to do, as opposed to doing it as a jigsaw puzzle.
Okay. So how long, once you're able to do it, or even now, how long does it take to grow an organoid heart?
So we're really not growing it. We're printing it. So once we have it's a matter of hours. It's not that long. But really, the long part of the process is the cell work that's involved. So going from that patient's white blood cells to the induced adult stem cells, the iPS cells, and then having those multiply in volume to have enough volume to print or to differentiate into all the different cell types, and then do that differentiation process. That's really where the bulk of the time is. The bioprinting itself is only a matter of hours, and then you're looking at, once you've bioprinted it, having that organ take a few days in order for that self-assembly process, that natural biologic self-assembly process where you go from having all these individual separate cells to all of them joining together. They know how to do that because the DNA in each of these cells, that knowledge bank, says, okay, we're now cardiomyocytes, we're cells that are supposed to beat, so our job is to join together and network with these other cardiomyocytes and start beating and doing all those things. So that natural biologic self-assembly process only takes a few days. So really the longest part of the process right now is the cell work up until the point where we're 3D printing.
Amazing. What happens once you create the organoid? Does it just sit there and function, or does it scar up?
No,
anything unusual happens to it?
Yeah, so once it's printed, really all the 3D printer does, unlike a typical 3D printer that fuses one layer to the next, you can't do that when you're working with cells because you'll kill all the cells. So what the bioprinter really is doing is just placing all of the cells in the right area, and then we lay down scaffolding, just like if you were building a house, to hold all of those cells in place. And once those cells are, after a couple of days, when all those cells have gone through that self-assembly process, we can then melt away the scaffolding and be left with the full organ. That takes place in what's called a bioreactor. And really all a bioreactor is a vessel that reproduces the conditions that's inside the body to keep that organ functional. So what it does is it provides not blood, but a fluid that's similar to blood in that it provides the oxygen and the nutrients and things like that are required for that organ to stay viable. And it gives it the process in order for those cells to release the waste products so it can keep all of those cells viable. So it remains in that biochamber, the bioreactor, for those few days afterwards.
Wow, this is amazing. Very cool.
It's an incredible process. You know, the most amazing thing is that we're finally at a point in human history where this is possible. Even 10 years ago, most of the science didn't even exist. So we're finally at a point where computing technology and software technology and bioprinting technology, all these different technologies that need to have evolved to the point where they're at now, we're finally at that point where we can bring this all together and get this technology out to the market. It's no longer science fiction, it's now science fact. That's probably the hardest thing. You know, when I first started to learn about it, I thought, wow, this is really cool. I get the concept, but no way, this is like Star Trek or Star Wars technology. And it wasn't until all of the people that we put together to form BIOLIFE4D, which is really a coming together of people from different silos of expertise. So you have biomaterial specialists and cellular specialists and bioprinting specialists, all these different people. When I put the company together, I went to each of them and said, tell me, really, where are we at with this technology? And everyone said the same thing. We're finally at the precipice. We now know what all of the pieces of the puzzle are. We just have to make those pieces fit. And that's what BIOLIFE4D is doing. We're kind of coming in just in the red zone, if you will, of all these people's career. They've spent their careers getting to the point where they're at in each of these areas of expertise, of these specialized areas. And all BIOLIFE4D is bringing all these people together to work together and get this technology out to the market.
That's great. So, Steve, do you have like visualizations on the website, or where can people see and experience some of this more instead of just only hearing?
Yeah, so we've got some really incredible videos on our website, which is www.biolife4d, BIOLIFE, the number 4, letter D.com. We've got, and the reason these are really great videos is because they're for non-scientists. So they're people like me that can watch this and really understand and see this technology and how it works and how it's being implemented. There's a lot of really good facts about the heart and heart disease and all of those type of things. Really, it's a great way to learn about who we are, what we're doing, and how we're doing it. So going to biolife4d.com is a great way to learn more about this incredible technology.
Excellent. Well, Steve, it's amazing what you guys are doing. Your team is doing what you're doing. So thank you for coming on the podcast.
It's my pleasure. Thank you very much for having me.
You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you've enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you.